speed, ultra high resolution camera which can capture 5000 frames per second, that is 100 times more than what a smartphone camera can do, was utilized to detect the smallest of aerosols possible. We conducted our experiments on enucleated goat eye with vitreous being stained with brilliant blue and used an Alcon constellation system for vitrectomy. Aerosol generation was ascertained for intravitreal injections, different gauges of trocars and cannulas, valve versus non-valve cannula for lensectomy and vitrectomy. Passive and active fluid air exchange, removal of cannulas and suturing. During intravitreal injection, insertion of cannula, lensectomy and vitrectomy with both 23 and 25 gauge instruments with either valved or non-valved cannulas, we did not find aerosol generation, which was confirmed on shadowgraphy. Even with a 20 gauge MVR blade, there was fluid flow but no aerosol. During active fluid air exchange, we did not find any aerosol generation. However, while performing passive fluid air exchange using a Charles fluid needle, we found bubbling and aerosol generation at the exit port of the annulus. As expected, under fluid air exchange with reused valve and fresh non-valve cannulas, aerosol generation showed a trajectory of 0.4 to 0.67 meters with droplet sized 200 microns. While removing cannulas or suturing under active air infusion, bubbling and aerosols were noted. Based on our experiments, we recommend use of valve cannulas whenever possible. To avoid passive fluid air exchange, even if done, direct the exit port away from the surgeon and the assistant. To maintain air pressure at less than or equal to 30 millimeters of mercury, to stop active air infusion or clamp the infusion during removal of cannula and suturing. Last but the most important, usage of adequate personal protection is mandatory. Based on these experiments, vitrectomy appears to be a safe procedure during COVID times.
Now this video is open for comments and discussions amongst this. Anything they want to ask questions to the assistant.
I don't know whether was spreading ocular fluid.
Was we had published a paper, the conjunctival surface had evidence of COVID. There was many publications on the ocular surface. The reason why we saw this was not because of the vitrectomy per se. The virus was never isolated from the aqueous or the vitreous in any of the studies. When you have an air fluid interface on the surface, there is a potential for these aerosols to form, and therefore they can carry the virus.
How about the no the HR, human involvement in this spread? Because a lot of patients become positive if they are infective. So the OT personnel's thing, how do you prevent that? Because probably that was one thing.
We were all wearing N95 masks. We were all
That
wearing
was
masks, and even during surgery, once we realized that the distance of the aerosol spread is that much, we initially started, of course, using betadine. So at least the ocular surface is safe, and then we ensured that during passive, if ever we use, the personnel were never standing close by. And also, everybody were wearing goggles, they were wearing masks, N95 masks, all OT personnel.
this is limited to only vitreous surgery, nothing to do with the
No,
phaco
actually, we
surgeries.
did all surgeries. We did experiments on all, but I'm only presenting retina data.
What was the environment of your experiments? You were doing it, conducting in the lab in a OT, because in a OT there are laminar airflows.
Yes,
Looked at that, comparing.
that's possible, but we couldn't conduct this at our institute because you can't get those cameras, those high speed cameras. They're only available in a lab setting. The experiments were conducted in Indian Institute of Science because those are huge equipment actually, and you need 2 or 3 cameras to capture the shadows of this aerosols.
Good. We also conducted a similar study with IIT Madras, the OT. But I'm not sure whether we use such high-end cameras. But even in the OT setting, it didn't change much. Do you suture all your 25 gauge ports also?
No, not
Not really. Another thing that can be done is you can suture with the trocar in place
In place.
itself.
Replace.
That time spent on suturing is
Absolutely.
Video, good presentation. Actually, you had done a lot of hard work. Then was shadowgraphy. I could not make out the full distance being captured. Maybe there were more cameras they would have captured. Question is, when you were doing fluid air exchange passive, what was the intraocular pressure that was made, or the air pressure? It vary, if you the air pressure to 60 instead of 30 or 20.
We started with 60, brought it down to 35. Till 35, we saw displacement. But when we came down to 30 is when we really saw no more aerosols. That's why we recommended to go at 30.
Thank you. Can we
Thank you. Thank you,
request
judges
the
and
next
panel.
person? I don't know who is available. Sangeet, Dr. Sangeet Mittal, and we have 30 seconds for the just to mark their score sheets. Give them 10, 20 seconds so that they do that job, and then we start. Opposite, yeah, you have to go to the other podium, Sangeet. Not have to. And we are not taking any questions from the audience. Sorry for that, because we have to stick to the time. And so, Sangeet, shall I start? Please go ahead. Sangeet is going to present peripheral streak
Can
of
I have the audio, please?
DR involves clearing of media opacities like vitreous hemorrhage, creating a proper plane of dissection, separating the posterior hyaloid from retina to expose the vascular epicenters, and dissection of pre-retinal membranes to relieve retinal traction. The pre-retinal membranes in these eyes are sometimes associated with second membranes, which is said to be due to schisis of the posterior vitreous. Meticulous dissection of all these membranes is required to achieve a good postoperative result. After removal of epiretinal membranes, residual vitreous is removed. A second layer of vitreous is again separated from the retina. This layer is due to schisis of vitreous. Complete shaving of vitreous is done to the vitreous base. Proportional reflux is used to disperse and remove the pre-retinal blood. This completes the vitrectomy, and the only thing remains is this streak of pre-retinal blood in the periphery. After spending a considerable time on procedure so far, we often tend to ignore this peripheral blood. But is this a sign to ignore? In this video we will try to see if this peripheral lining of blood is of any clinical importance or not. Once we started teasing this hemorrhage, we found a small opening. After a little more effort, we were able to peel another layer of vitreous from the retina. It was a surprise to see the amount of vitreous still present in the eye. Let's see whether this is a one-time phenomena or not. This was another patient with vitreous hemorrhage and TRD. A thorough vitrectomy was done. Vitreous was shaved up to the base. A streak of peripheral pre-retinal blood was seen. On applying suction at this blood streak, vitreous membrane was separated from the retina. This membrane is quite adherent to retina and requires some effort to peel it up. The peeling has to be done from anterior to posterior rather than posterior to anterior. Again, see the amount of vitreous remaining even after thorough vitrectomy. This is another case in which a modified en bloc dissection was done. All pre-retinal membranes were peeled, dissected and removed. A very thin and aqueous streak of hemorrhage was seen unfairly in the mid-periphery. On teasing the membrane again, a layer of vitreous was revealed and separated from retina. In the end, it could be said that the presence of peripheral streak of hemorrhage means incomplete removal of vitreous. This layer of vitreous is tightly adherent to retina and may need the use of triamcinolone or peeling of ILM to separate it. Active suction should be applied in anterior to posterior direction to peel this layer. Peripheral blood lining is not a red herring and cannot be ignored. It may be a sign of vitreoskisis. It is a red flag.
Thank you. This video is open to discussions amongst the judges. Yeah, Girdhar.
Sangeet, a very nice video. I think in all the cases you have done posterior to anterior, right? Not from. I
From
mean,
the center to the
it's
periphery.
inside out. Basically, I think. I mean, as you said, triamcinolone, I think, is a very important adjuvant in any diabetic vitrectomy. I think in the end, it's nice to diluted triamcinolone, smear it on the surface, and that tells you about very residual vitreous membranes. These are all combined procedures or pseudophakic eyes?
Most of them were pseudophakic eyes.
Pseudophakic eyes. Phakic eye is sometimes
Difficult to actually reach that area.
Yes. So you may find it very difficult to. It also raises a question whether in diabetic vitrectomies, whether we should, like Japanese style,
All eyes are pseudophakic.
always go for a combined procedure.
Again, very nice video. What the retinal hemorrhage in the periphery is implying is thyroid. But does it necessarily mean that you should start pulling on the hemorrhage side, go from in, including ILM peel, but lifted can be risky sometimes to peripheral.
It can be. It is actually very adherent to the retina, and sometimes it may lead to retinal breaks. But then we have done a study, a prospective study, comparing the membrane and then to remove the membrane. We have seen that the incidence of the vitreous cavity hemorrhage, the late vitreous cavity hemorrhage, and the incidence of epiretinal membranes is more in which this peak.
So I'm not saying we should leave the streak. Yeah. Go ahead, but start from the usual safer way.
It's not possible from center to periphery, so you can't make it out properly. You always have to come from the anterior to.
You can use nanos. That's what we do. It and maybe get out also.
A fantastic video, Sangeet. Vitreochiasis is a known phenomenon in PDRs, and we are always looking for second membranes. So this pre-retinal heme is a good sign, like you've demonstrated. But has it changed your approach in any way? Like in all your diabetic vitrectomies now, even after you're sure are you multiple times putting tricort, or because you may not have the pre-retinal hemorrhage every time, but there still could be some raised cortex there.
Yes, definitely. Because this was an eye opener for me, because we finished the vitrectomy, we do everything complete, we had done everything, and I came to know about it because when I tried to remove the vitreous in that area, it was not coming easily into the cutter. So that was one thing that prompted me to see whether there's anything left, because why is this vitreous not coming into the cutter? So when then we explored it, and then we found that this is another membrane which is still remaining even after I have completed my vitrectomy. In most
so nice, Sangeet. Before you leave, I just have one question.
Yes.
Do you change your viewing system when you're going to the periphery?
Do I?
Viewing system vitrectomy. In extreme periphery, do you continue with the same?
I use the same non-contact white field.
Non-contact. Okay. Thank you so much. The judges have few seconds to mark. Who is the next? Mondal is there? Yeah, because Ajay is still running. So please come, someone. When the globe is a Pandora box, two IOLs and a retinal detachment. Over to Soman.
A 65 years old gentleman presented with diminution of vision for about an year in the left eye. He had a history of cataract surgery about 3 months ago elsewhere, followed by another intraocular surgery at yet another hospital about a month ago. On examination, his best corrected visual acuity in the left eye was 20 by 400. A retrofixated iris claw lens was then implanted in the eye. Posterior segment examination revealed a total rhegmatogenous retinal detachment with multiple breaks along with a dislocated intraocular lens in the vitreous cavity. 25G pars plana poles were made. A superior sclerocorneal tunnel was made. On entering the vitreous cavity, pars plana vitrectomy was initiated, followed by injection of triamcinolone to ensure the complete detachment of the posterior vitreous. Perfluorocarbon liquid was then injected to stabilize the retina as well as to protect the macula if the IOL drops while removal. The dislocated intraocular lens was dislodged from the entangled peripheral vitreous. After making a side port for manipulation of the retrofixated iris claw lens, the sclerocorneal tunnel was completed. When tapped on the retrofixated lens gently with a dialer, hanging like a hammock from the iris, it opened up like a trapdoor. The dislocated intraocular lens was planned to be removed via this trapdoor. The dislocated intraocular lens was held firmly with a max grip forceps by the non-dominant hand and brought up anteriorly. The anterior chamber was entered with a dialer via the side port and the retrofixated iris claw lens was gently pushed, creating an easy exit port for the posteriorly dislocated IOL. The intraocular lens that had been dislocated was now explanted via the sclerocorneal wound. The retrofixated lens fell back into its original position as soon as it was left alone without any injury to the enclaved iris. This was followed by all the routine steps of retinal detachment surgery. Vitrectomy was completed, followed by fluid air exchange. As has been shown, the retrofixated IOL allows good and stable visualization all through the vitrectomy surgery, even during the fluid air exchange. Endolaser and silicone oil injection. After 3 months of postoperative period, the silicone oil was removed. The intraocular pressure was normal during the whole postoperative period. The best corrected visual acuity following oil removal was 20 by 50.
Thank you so much. Open to discussion with judges.
I think there was a very nice maneuver that you did. Fantastic video. Maybe I would have done it slightly differently. Of course, your method was also very good. What I would have done is maybe just use 2 iris hooks, retracted the iris at 12 o'clock. Would have given me enough space between the iris claw lens and the superior limbus to pull the IOL. There was a risk that while doing this maneuver, my iris claw could have given way. But of course, I think you achieved a equally good result then.
Any problems with fluid air exchange with the iris claw lens?
No, I mean,
Didn't?
I didn't
That was
find it. Actually, that was the there were two
biggest problem there.
there were two aims for showing this video. Number one was that even during fluid air exchange or during oil injection, I didn't find any problem with the iris claw lens in position. Number two was that the iris claw lens, it just moves like a hammock and it opens as a trap door. So it's contrary to what I would have believed before I did this surgery. It's very easy to remove any intraocular lens, any dropped IOL by that trapdoor.
Good video. I just had a question for you. Do you think this is a reproducible step? enough guarantee that the IOL, second IOL will not dislocate inside?
I if now what I did initially before I did this, before I maneuvered, I tapped the iris claw lens with a Senske hook to see whether it's stable or not, whether the enclavation has been done properly or not. If that is proper, then I think this is reproducible. When I was taking the lens out, I tried to be a little less than normal. And I think that was somewhere around 40.
Why did you inject oil? I mean, it didn't look very hardly any PVR. Any particular reason you injected oil?
Uh, yes, actually,
That was your choice.
because I was dealing with this ret detachment was a little older. The patient came to me after about 1 month with a 1 month of history. So I thought I'd better achieve intact retina with oil.
Very nice video. Had a clarification. Has described by anyone else earlier?
No, I don't. I searched literature, but I didn't find any other reference.
The lighter note, actually, the couldn't see the trailing haptic coming. Actually, it was broken already, or it was broken inside.
It was broken. I mean, I couldn't show it within this 4 minutes of time.
Okay, it broke within the vitreous.
Yeah,
we
it
were
broke
manipulating.
initially while removing, and then I took it separately.
A great observation, Mahesh. Thank you so much, Somen. Very good surgery.
Sure.
Uh, judges have 30 seconds. So the
Judges.
next video is by Dr. Mudit Tyagi. We're going to talk on no oil, no gas, fibrin glue. Over to Mudit.
So in this video we describe the use of fibrin glue in taking care of rhegmatogenous retinal detachments and where no oil or gas tamponade has been used. So the surgical technique involves essentially a lot of steps which are common. In a case of a retinal detachment, first of all a complete thorough pars plana vitrectomy is done. Subsequently the break is flattened with the help of a fluid air exchange, and then in a air filled globe a laser is done around the break. Subsequently, in an air-filled globe, after completion of a laser around the break, instead of putting oil or gas, a drop of fibrin glue is placed over the break so that the glue tamponades the break and acts as a plug over here. So this was a 60-year-old lady who presented to our clinics with a visual acuity of 20/500 and a subtotal RD. So a 3-port pars plana vitrectomy was done, and subsequently a complete vitrectomy was done and all the vitreous was removed. So the peripheral retina was examined and a superior break was also noted. So an inferior drainage retinotomy was made and a fluid air exchange was done and the retina was settled. Subsequently, laser was done around the inferior drainage retinotomy as well as along the superior breaks. After that, in an air-filled globe, a drop of fibrin glue was placed over the inferior retinotomy as well as over the break. After putting a drop of fibrin glue over the break, you wait for 2 to 3 minutes, and 3 minutes you can see that a fibrin coagulum forms, and this coagulum can be gently lifted with the help of either a flute needle or with the help of forceps, and is needed to be reposited over the break. So you can see this coagulum being lifted, and this can be gently repositioned with the help of a forceps or with the help of your fluid needle, and just needs to be placed over the break. So after the fibrin glue plug has been noted to adequately cover the retinal breaks, the surgery is completed and the ports are closed. No post-operative positioning was given in this patient. So the next post-operative day we can see an attached retina with a fibrin glue coagulum covering the inferior retinotomy area, and superiorly a small residual air bubble is left behind. The visual acuity on the first post-operative day itself has improved to 20/100, and at 1 week the entire fibrin glue coagulum has got resolved, and now we can see an attached retina with laser marks around the breaks, and the visual acuity has improved to 20/80, which was maintained at 3 months and even at 6 months of follow-up. In conclusion, we believe that fibrin glue can be used as an effective tamponade in cases of early simple rhegmatogenous detachments. It can help in avoiding the need for postoperative positioning and can obviate the problems associated with conventional oil or gas tamponade.
Thank you, Mudit. The video is open for discussion amongst the judges. Any comments?
So the concept is the glue essentially prevents any fluid from going under the brake. That's the concept.
The thing is that if we look at it conventionally, the strength of a laser retinopexy is achieved within 3 to 4 days. That's what most studies have shown, that we can achieve an adequate strength of laser within 3 to 4 days. So what you need as a tamponade agent is just a thing which can prevent fluid from egressing back inside once we have done a complete retinopexy. And we have found that fibrin stays for at least 1 week to 8 to 10 days, a time which is sufficient for the effect of the retinopexy to set in.
Air also stays inside the eye for 5 to 7. Left the air. The tamponating effect of the air, which is additive. If it is fluid with the fibrin glue, then we can say that there is no tamponade. But air is also very good tamponade for RDs, especially a fresh, simple RD like.
Accept that. But the thing is that usually, first of all, in any of these patients, do not give any post-operative position. Have a tamponade of air. You will also need to give them a post-operative position, what we don't want to give. So none of our patients needed any post-operative position. That was not given. Plus, the air fill is usually partial. So even if you can see on the first post-operative day, the image which I had shown, there was only a partial small air bubble which was just covering the superior half of the retina. The inferior break is not covered by the break, by the glue. And a lot of our cases in which we have done happen to be inferior RDs also. So in around 46 cases which we have done till now, of them around 29 are inferior retinal detachment.
It's a superior primary break. Superior one was iatrogenic in the sense it's a drainage retinotomy. That usually doesn't need tamponade.
Yes, so I accept the point, but the thing is that anyways, even otherwise, for you to use there as a tamponade, you still need to give them a position. Here we don't need to give them positioning. This was just one video, but in others also where we have drained through the inferior breaks also, in none of our patients we have needed to resort to giving any post-operative position.
This is basically an off-label use of the fibrin glue. Any toxicologies?
None. That's the best part. There are already multiple studies which have shown in even animal eyes the fact that fibrin glue is absolutely not toxic to the retina or the RP. In fact, we have earlier used fibrin glue even for macular holes. There are reports of it way back, and for optic disc pits also it has been used. This is one agent which fortunately is not toxic to the retina also. So that also basically allayed our concerns.
How much time it lasts there, or does it peel off, or what happens to the plug which you have put it there?
It gets absorbed. So like I showed in the video,
gets
sir.
absorbed.
Yeah, it gets absolutely spontaneously absorbed
How much
within
time?
7 to 8 days.
So can it be an alternative to plugging large macular holes also, you think?
I have, to be honest, tried it in large macular holes also. We have done a study, but the results are not as consistent with large macular holes somehow. Maybe there's something which we still need to improvise upon, but at least in detachments it's working very well.
Thank you so much, Dr. Mudit.
Comment on that I did use it for macular holes. Hole closes, but there's a lot of RP atrophy.
RP atrophy, yeah. Anyway, may I have the next speaker, Thirumalesh? Is he here? Okay, after that, Mohit Dogra. I see him here. Yeah, Mohit is here. So, Mohit is going to talk on white, his video is on white cornea with detached retina, story of a post-trauma eye. Over to you, Mohit. Your time starts now.
This video discusses the management of a patient who had opaque cornea with retinal detachment. Our patient is a 46-year-old farmer who was involved in an accidental blast which led to 30% body burns and bilateral open globe injuries. The open globe injuries were repaired elsewhere and he was referred to our center 10 days later. The left eye on examination was tricycle with no light perception, while the right eye had light perception with a totally opacified cornea and dense vitreous membranes along with retinal detachment on ultrasound. He was planned for right eye temporary keratoprosthesis assisted pars plana vitrectomy and optical keratoplasty. After marking the center of the cornea, a suction trephine was used to incise the cornea up to 80% of its thickness. This was followed by removal of the corneal button with the help of scissors, and an open sky intracapsular cataract extraction was then performed. Eckhart's temporary keratoprosthesis was sutured in place and a 3-port 25 gauge pars plana vitrectomy was initiated. Thick sheets of dehemoglobinized blood mixed with vitreous was slowly removed and an opening was eventually made in the supranasal quadrant to visualize the retina. The superior retina was attached, however the macula and the inferior retina weren't. Vitreous was found to be adherent around the optic disc and internal limiting membrane forceps were needed to peel it off the retina. Multiple chalky white intraocular foreign bodies were noted, along with a large infranasal break which had subretinal blood and more of these foreign bodies. The vitreous cutter and forceps were used to remove these foreign bodies one by one through the anterior route. Trillium blue-green dye and perfluorocarbon liquid were used to stain and remove residual membranes. And a relaxing retinectomy was made nasal to the optic disc in the region with extensive subretinal gliosis. Once the retina was adequately relaxed, perfluorocarbon liquid was filled up to the brim. An endolaser was done around the break and 360 degrees to support the peripheral retina. This was followed by direct perfluorocarbon liquid and silicone oil exchange. Temporary keratoprosthesis was removed and an optical quality cornea was sutured with multiple interrupted 10-0 nylon sutures, with silicone oil being infused as and when required and when hypotony was encountered. Post-operatively, he was treated with oral and topical antibiotics and steroids. At 3 months follow-up, he had a best-corrected visual acuity of 3/60 with an intraocular pressure of 9 millimeters of mercury, a clear graft, and an attached retina under silicone oil. Thus, thorough pre-operative assessment, meticulous surgical planning coupled with patience, persistence, and perseverance are essential to tackle these badly traumatized eyes. Thank you.
Thank you so much, Mohit. Great video. The video is open to discussion, sir.
Is it a heavy silicone oil you used or
No,
just the routine silicone oil?
just regular, but so not heavy, but 5,000 centi.
Okay. Okay.
I don't think
Great.
the situation ever will be able to get the oil
It's a
out.
great effort. Fantastic video also. Have you the post-op shows a lot of pre-retinal membranes.
Yes.
Are you going to tackle that or you're just going to leave?
So I have 9 months follow-up on that, sir. The patient also has retained subretinal PFCL bubbles, which was also shown, but it's not under the macula. I have a couple of bubbles nasally. Yes, I would want to tackle that, but I'm actually giving it time because I don't see any pressing indication. It's not, the macula is not coming off. There is epiretinal membrane formation outside the area of the ILM that I'd peeled, but I think that's holding on, and as am I, sir.
It was done under general anesthesia or local?
This was done under general anesthesia, sir.
Done by a team also, right?
This was absolutely, sir. So the actual video was actually longer, and that had the names of the corneal surgeons also. So the initial part in which the graft was actually marked and cut and incised, and the ending when the cornea was sutured was done by my cornea colleagues, sir.
I didn't see
Yeah,
the use of
the pupil was, I mean, how was the iris like? I mean, there was enough iris?
Yes, absolutely. So I didn't need to incise or abscise the iris. I mean, it was already.
I was just asking that because possibility of oil coming into the anterior chamber.
Absolutely, sir. So the thought that we might need those hashtag retention sutures did cross my mind, but quite frankly, at the end of all of that, very prolonged GA time, and whether the eye would actually tolerate any more sutures or whatever in that area, I've actually not done it, but the thought did cross my mind.
Just one more question to the audience. I mean, tell the audience as to, the breakthrough vitreous hemorrhage sometimes is really a challenge. So dense. Any key points as to, because B scan is very useful.
B scan, sir, absolutely.
Right, to start, opening up. Any key points would you like to say?
Absolutely. I think amongst a lot which has been discussed, I think one key point which I also highlighted in the narration of the video is I think after you go slowly and you've removed like fair few sheets of blood, I think there is a point where you have to take that leap of faith, and you would normally want to do it in the upper nasal quadrant. That even if you, God forbid, hit the retina or there's a bleed or whatever, it's manageable, and then that can also once that one quadrant is exposed and you're able to see the retinal vessels, and then it's easy to come around and do as I've done here, sir.
Very, very nice video, and especially teamwork. Amazed, the also look clear. 9 months, you said. Is there anything for the audience that you would like to reiterate as what is new in this?
Nothing new, sir. Nothing new, sir. It's a good outcome of a technique which is been there for a long time. But I think the not too many of these get shown for some reason. Primarily because I think getting a good video out of them, the surgery is challenging, backbreaking, but getting a good video out of them is not easy every time, and the outcome is not satisfactory on a lot of counts. I mean, this patient, I'm very sure down the line will require oil for like ever, because that's the only eye, will have low pressures and all of that. Maybe people tend to not show as many of these at conferences.
Patients.
Very nice video.
I didn't see a use of Flaring here.
Ring.
Ring wasn't used, sir. I think again that call was made by the corneal team, sir. And I think the fact that this wasn't a vitrectomized eye.
But later stage, when you have a vitrectomized eye, the oil fell. You think the oil will keep leaking and
it did, sir.
Complete.
Absolutely, sir. It did, but I think once there's oil in the eye, I think it provides enough, for the corneal suturing. I think it provides enough kind of resistance for the.
Okay, let's close it here, and the judges for their marking. The next, Dr. Veer Singh is here. Yeah, Dr. Veer Singh, he is going to present his work on mini PVD technique in flat sticky membrane diabetic vitrectomy. Time starts. So please on his video.
In this film, we shall be showcasing our mini PVD technique that we specifically use in vitrectomy surgery for treating flat sticky membrane PDR cases. In flat membrane PDR cases, such as this one tries to find a membrane edge as shown by the arrow to initiate membrane dissection. Unfortunately, many a times, there is vitreoschisis, and the surgeon ends up in the false plane. This is where our mini PVD technique comes in handy. In the mini PVD technique, there is no need to search for a membrane edge. Instead, we create a tiny PVD at the optic disc to start membrane dissection, called as mini PVD. The hyaloid is carefully and safely lifted up from the disc just by a millimeter or two. This creates a small PVD measuring about 1 disc diameters around the optic nerve head. Further, opening up this mini PVD gets the surgeon in the correct plane under the second membrane. Once the surgeon is in the correct plane, and there is a 360 degrees membrane edge at the disc, the dissection is rather straightforward. This technique saves the surgeon the time needed to search for a membrane edge, prevents the surgeon from getting into the false plane, and even the most challenging flat sticky membrane PDR cases can be managed very efficiently and safely, with very low incidence of break formation or any tamponade requirement. Case 1 is a flat fibrotic membrane. Notice the flat nature of membranes and the absence of a PVD. No attempt is made to find a membrane edge. Using forceps, a mini PVD is induced at the disc. This creates a membrane edge. The cutter is then engaged at this edge to initiate membrane dissection. This maneuver gets you in the correct plane under the second membrane. Once in the correct plane, the dissection is fairly easy and effortless. Since the nasal membranes are strongly adherent, forceps are used to create a mini PVD on the nasal side as well. This creates a nasal membrane edge to work with. Once this edge has been created, the membrane comes off easily using fold-back cutter delamination. The PVD is further extended into the periphery using suction, and the cutter is used to chew up the loosened up membranes. Finally, the last bit of the membrane is removed, and the case is concluded after doing endo laser. In case 2, with an extensive flat fibrovascular proliferation, the mini PVD technique comes to the rescue. A mini PVD is induced by slightly lifting the hyaloid at the disc using the forceps. Opening up this mini PVD creates a membrane edge in the true plane. Engaging this edge with the cutter, the fibrovascular proliferation is segmented all around. Since this membrane edge gets you in the true plane, the cutter segmentation is fairly effortless. Simultaneously, the loosened up segmented membranes are delaminated and removed using the cutter itself. Next, the inferotemporal fibrovascular membranes are removed. Lastly, the nasal membrane edge of the mini PVD is attacked to finish up the membranes and conclude the case without any iatrogenic breaks. Case 3 is of a macula off, extremely adherent, flat, and a tough fibrovascular proliferation. The case is started by trying to induce a mini PVD at the disc using forceps. After multiple failed attempts, slowly and cautiously, a mini PVD induction is finally achieved. Due to the extremely adherent nature of the membranes, forceps are used to extend the mini PVD beyond the arcades slowly and steadily. This loosens up the fibrovascular proliferation and creates a well-delineated membrane edge for the cutter to engage. The loose membranes are segmented, creating small islands, which are delaminated and removed one by one, gradually working circumferentially. Even such a tough and strongly adherent membrane is completely removed with great ease, thanks to the mini PVD technique. Here again, there were no iatrogenic breaks, and the OCT showed drastic improvement at 2 weeks follow-up. Thank you for your attention.
Thank you so much, Dr. Veer. It's open to discussion now.
It's nice demonstration of the EPVD technique. I saw most of your videos had mainly fibrous membranes, not that much vascular. So is it because you had given pre-op Avastin, or you're using this only in those fibrous membranes and not so much of vascular membrane? That is one question. I'll put my second question also. And the second question is, when you're lifting up from the disc, there is a chance of bleed, right, from the disc. Are you doing any IOP variation at the time when you're actually inducing the mini PVD technique? Two questions.
Thank you for the question, sir. So basically, I don't limit this technique for any fibrous or non-fibrous membranes. Most of these cases do have an intravitreal anti-VEGF given. Depending on the vascularity, I give the anti-VEGF maybe 2 or 3 or sometimes even 5 days before. But as a result, the bleeding is less and you see the more fibrous nature when it's shown in the video. And the idea of, I usually use anti-VEGF in cases where there's flat membranes and there's no PVD. In case there's a PVD, then I don't really need to anti-VEGF. So these are 25 gauge cases. And so the second question was?
The time of lifting the technique, are you using any IOP, like you're increasing the fluid pressure?
So I most of the time go up to 60 millimeters of mercury, and then I do this.
Mike.
What are the parameters I have? Not for the mini PVD, but for the further dissection. Because some of these focal attachments are quite dense. They don't come off. They can create iatrogenic breaks. They are always, the hiatus of the focal attachments are close to a large vessel. Basically, that's why I asked, what are the parameters that 7,500 cuts?
In all these cases, I've used the 10K beveled cutter.
10K
so
cutter.
it's usually 10K, and the suction varies. So sometimes I come down to 350 also, but most of the cases are done at 400,
So you
450.
use the
Nice videos. Some of your mini PVDs were not really mini. Did extend more. What are the pitfalls of to stretch the limit of your
So the only
field?
thing that I consider while doing this maneuver is I make sure that I don't pull on the hiatus, hiatus is the fixate, the points which are around the disc. So I'll take them up to that area, but not beyond that.
So we have seen one of the earlier videos by Sangeet, where he has also kind of initiated a mini PVD, but still had a second membrane. Have you seen any of those peripheral red herrings?
I have seen that in a lot of cases, sir. That's why I said that vitreous is present in almost every case.
Okay.
And
Thank
I
you.
use tricot at the end in almost every case. And there's usually a membrane, but I don't touch all the membranes.
Thank you so much. Thank you so much. I now request Dr. Ajay Arora to please come for his macular hole novel closure with a differential ILM map. I request the audio people to AV people to please put his video. Ajay has just finished his 10-kilometer marathon, so don't ask him too many questions.
No, I'm okay, absolutely fine. I'll be presenting before you a novel technique of closing an asymmetrically large macular hole by a differential flap. I call it DIMS, a differential ILM flap macular hole surgery. The treatment options for closing a large macular hole are inverted ILM flap, a petaloid technique, or the cabbage closure technique as we had described it in 2017, free ILM flap, lens capsule or amniotic membrane, or an autologous neurosensory retinal flap. This was a cabbage closure technique described by us in 2017. So here is a 61 years old female with a blurred vision of 1 year duration who is non-diabetic and non-hypertensive with a visual acuity of 6 by 36, and there's a large symmetrical macular hole. I call it symmetrical because the arms AB and CD are similar. The angle alpha and beta are also similar. Hence, this can be closed by a petaloid technique with the flaps being equal in size. When they cover the macula, they exert a large centripetal force covering the macula. So let's have a look at the surgery. This is a standard vitrectomy is done. Vitreous is removed assisted by triamcinolone, which helps us to induce PVD and remove the entire vitreous cortex. Once the vitreous is completely removed, we stain the ILM with a dye which is either ICG or BBG. Here it's stained with ICG. The inverted ILM flaps are being created. The second flap has been created now. And you can see that every flap has a retinal surface and a vitreal surface. And one flap covers the vitreal surface, covers the other flap's retinal surface. Excess ILM is removed and a fourth flap is being created which covers the third flap. This is followed by a fluid air exchange, followed by a fluid gas air gas exchange. So this is the post-operative picture. The macular hole is nicely covered with the visual acuity improving to 6 by 24. You can see the remnants of the ILM over the closed hole. So this was a symmetrical closure using the petaloid cabbage closure technique. So now let's look at asymmetric large macular hole. This is a 56 years old female with blurred vision for 3 months, has a grade 4 large macular hole with slanting neurosensory edges with a visual acuity of 6 by 16. If we close it by a normal method of petaloid closure, the probable result would be that the hole will close on the surface Coming
but
here,
not
but it's
close
not coming
underneath,
there.
leaving behind either an inverted L-shaped open area or the inverted
AV people, please
V-shaped open
rectify
area.
this error.
Hence we decided to
Can you
close
pause
it in a
it?
different manner.
I
This
can't
is
pause,
what
I can't do anything. I can see it here.
You can pause the video here.
Can?
Yes, AV people, can we Find out why it's not happening. It's not coming here. It's on his screen.
over the closed macular hole.
It's come.
So this was a symmetrical closure using the petaloid cabbage
Please.
closure technique.
It's not coming there.
So now let's look at asymmetric large macular hole. This is a 56-year-old female with blurred vision for 3 months, has a grade 4 large macular hole with slanting neurosensory edges with a visual acuity of 6/16. If we close it by a normal method of petaloid closure, the probable result would be that the hole will close on the surface but not close
Don't
on
worry,
the
please
leaf,
finish your video.
leaving behind either an inverted L-shaped open area or the inverted V-shaped open area. Hence we decided to close it in a different manner. This is what shows that why the hole is asymmetric, because the arm AB and ED are not of the same size. Similarly, angle alpha and beta are not similar. Hence we created two flaps, flap 1 and 2, which are based on the nasal edge of the macular hole. These are large flaps which are covering the macular hole and going onwards towards the temporal side. The temporal third macular flap is created, island flap is created, but it is removed. This is a superimposition of these flaps onto the actual fundus image. You can see here flap 1 and 2 starting from the nasal edge of the macular hole going on to the temporal side covering the macular hole. This is the video which shows how this was done. A standard approach where vitrectomy is done assisted with triamcinolone, which helps us in reducing the PVD, and once this is done we stain it with BBG. So once BBG staining is done, we are inverting an ILM flap. We start from the superior border and cover the nasally cover the macular hole, create a second flap which covers the first flap so that the retinal surface of the second flap covers the vitreal surface of the first flap. Then the excess ILM around it is removed. This helps in reducing the tangential traction. Similarly, the temporal flap which was to be put is also removed, and the flaps we ensure that the flaps stick to each other. This is followed by a fluid air exchange which ensures that there is no fluid remaining onto the disc surface, and this is done with using a soft tip cannula till we achieve a completely dry retina. And we also ensure that the flaps have not moved and are maintaining the position as was done once they were
It's just finishing. Actually, it was 4 minutes old.
Having done this, we remove the cannulas. And this is followed by introduction of C3 fit gas with a gas air exchange.
Thank you so much, Ajay. A short comment so that we can the time. If there's anybody who wants to comment, otherwise, the next video is by Dr. Thirumalesh. Yeah. Any comments, sir? Okay.
I basically we are a little confused whether the video was 4 minutes or.
It's okay. I think there
It was a 4 minutes video. I don't know why it was showing.
Showing
It was
a
4 minutes.
Anyway, the mistake was also from AV side. So there's no comments. I can thank you so much. Rumalesh is going to present do-it-yourself suprachoroidal needle for suprachoroidal injections. Request the AV people to please look after this glitches. Please start his video, Thirumalesh.
In our video, we will be discussing the steps of assembling a needle for suprachoroidal delivery of drug and technique to deliver the same. Materials required: 26 gauge needle, 22 gauge Winflon IV cannula, 15 number blade with Bart Parker handle. As shown here, length of 26 gauge needle is 11.5 mm. Keeping this in mind, 22 gauge Venflon IV cannula is measured for 9 mm length and is cut. Care should be taken for the end to not rebound off the sterile area. Then we assemble 9 mm long cut part of cannula over 26 gauge needle in such manner which leaves 200 micron of the needle end exposed. With this technique, 2 suprachoroidal injection can be made from one cannula. In this patient, we planned intravitreal injection of anti-VEGF with suprachoroidal triamcinolone acetate injection in same sitting. 3.5 mm from the limbus at pars plana zone, intravitreal anti-VEGF delivered. AC tab was taken to decrease the eye pressure and allowing the injection in suprachoroidal space as much as 200 microliter as shown here. Entry should be made at 45 degrees for 200 micron of exposed needle part. After gently removing the needle, there was no regurgitation of the drug. This ASOCT captured suprachoroidal space in its usual state, wherein this picture, which was taken post suprachoroidal injection, delivery of the drug can be confirmed in suprachoroidal space. Immediate post-injection montage fundus photo showing clarity of the media and thus reconfirming complete delivery of the drug in suprachoroidal space.
Thank you, Tirumalish. Comments from the judges?
Yeah, actually, we were having commercial needles made by Clearside. Yeah. But the trial done by them, both Topaz and stopped saying that there is advantage. Really continue with pedal injection.
Not about is about
Speak on the mic, please.
sorry. So the video is to demonstrate that the space can be accessed. What we were developing was in a quest for because we are developing vectors in our place. So when we contacted Clearsight that can we get the device so that we would want to check delivering of a particular drug or a vector into a super. They've entered into a contract with the. So why I presented this video was ensure that people know that suprachoroidal space access. There is no real requirement of a drug that of a device that is specialized and you have to buy from somebody. And this kind of makes it public knowledge that do not require an expensive device from a particular company to enter a contract with somebody and say that we are. Despite writing it, they said that we will not sell you that. So like you said, TA probably is not really very effective in treating cases. I do agree, but with upcoming cell therapy and gene therapy, because for subretinal delivery of the vector, you have to do vitrectomy, induction, retinal detachment, make a retinotomy, and then deliver the drug. So what I showed here, where we deliver the drug, we have done further studies to check whether they do reach the macula or not. They definitely reach the macula. So this video is to show that the space can be accessed. There is no need for a new device, and you can do it with whatever is available.
Whole thing is we have got one more innovator in the name of Dr. Ajay Arora. He has also done
He has a patent. I am aware of that, sir. And it's also very similar, but he has made a device which stop it.
The sleeve stays there, or you have instances where it slips off from the tip? Because you're just
We have done about 20 cases in our pilot, sir. Basically, I was accumulating data so that we write it to our collaborators that there is no real requirement of the Clearsight device. What they advised was we want of pilot data. In the cases that I did, I never had this.
Because
yeah, because you're going to cap the needle, keep it, on the trolley.
no, sir. We prepare it at the time of injection.
Yeah, but still
Only
there
at
is
that
some
point.
latent period, right? So I'm just asking you from the practical aspect that have you had instances where it slips off?
I have not had it.
Thank you. Thank you so much. The next video coming from Dr. Rajesh. Please start his video. Not so minimally. Onto the other side, yeah. Not so minimal for minimally invasive surgery. Dr. Rajesh Ramanuj.
I don't.
Surgery, we describe our technique of using a 26 gauge needle over a 41 gauge needle in performing retinotomy. 41 gauge needle is housed over a 30 gauge cannula for its easy insertion through a 23 or 25 gauge vitrectomy port. Sharing our experience with 41 gauge needle through a 23 gauge port, performing a routine 23 gauge pars plana vitrectomy for clearing the vitreous hemorrhage, we were able to visualize the subretinal bleed. We were trying to create a small retinotomy using a 41 gauge needle, but the unstable and malleable nature of the needle was creating transmitted forces at the tip, which created an inadvertent retinotomy extension. A second attempt at a different site caused an iatrogenic retinal break. When we analyzed the cause for retinotomy extension, we found that the unstable and unsteadiness of the 41 gauge needle was owing to the fact of large bore of 23 gauge port in relation to 30 gauge cannula over which the needle was housed. This, in addition to its malleable tip, has resulted in undue transmission of the forces resulting in retinotomy extension. Hence, we came up with an idea of using a cost-effective, readily available 26 gauge 1.5 inch needle for creating retinotomy, which is snugly fit to the 23 gauge port, making it steady, thereby creating a retinotomy of intended size. Presenting here is a case of a 69-year-old male patient who presented to us with best corrected visual acuity of counting finger close to face in right eye with persisting submacular hemorrhage secondary to PCV, status post multiple anti-VEGF injections. After completing vitrectomy, we had used 26 gauge needle to make retinotomy incision followed by air injection subretinally to create a smooth plane underneath it for distribution of RTPA drug. Due to buoyancy forces, air bubble moves up, blocking the retinotomy site, thereby preventing its efflux into the vitreous cavity, thereby creating enhanced bioavailability of the drug. SF6 gas and anti-VEGF was injected into the vitreous cavity subsequently at the end of surgery. 1 month post-operative picture shows the hemorrhage to be cleared away from the macula with regaining of near normal foveal contour and improvement in visual acuity to 6/60. The second case was of a 62-year-old female with visual acuity of 6/60 in left eye with vitreous hemorrhage and submacular hemorrhage secondary to neovascular AMD. Subretinal hemorrhage of around 10 disc diameter was found to be located at the posterior pole. We performed the same procedure of injecting air bubble underneath the retinotomy created through a 26 gauge needle followed by subretinal RTPA injection along with intravitreal anti-VEGF and gas tamponade. 1 month post-operative picture shows the heme to be displaced inferiorly with relative flattening of the foveal contour with improvement in visual acuity up to 6/24. Similar procedure was carried out in another 5 patients with good results. 26 gauge needle, which is cheaper, stable and readily available. Retinotomy created would be of intended size and self-sealing. Injection of air bubble subretinally before the drug injection enhances its bioavailability by preventing its reflex. Thanks for watching.
Thank you so much, Rajesh. Open to discussion now.
Good innovation, Rajesh. This video, I was wondering if when you use the 26 gauge compared to 41 when you inject, I saw in one of the cases the fovea, it went across the fovea or injection also. Is there a higher risk of creating a macular hole? No, it has been created in some.
It's more related to the syringe that we are using rather than the pressure of the needle per se. So if I use a 2 cc, it was pretty difficult. So the subsequent videos, I've used a 1 cc tuberculin syringe where the the injection is much smoother. Or even if I want to use a 2 cc, we need to remove the rubber stopper. Rather than it's not the resistance of the needle, it's more the thing. In fact, if you look at vice versa compare, 41 will be much more harder to inject because of the bore is lesser. It's more of the syringe which is to do with the resistance.
Points. One is using an expensive anti-VEGF. Why can't you buy a fresh 40 gauge needle for every case? Number one. But on the lighter note, the presenter was saying malleability. Malleability means to a sheet actually. It's more for ductility.
Yes, sir. It's more of the malleability. I mean to say it's the maneuverability. So that's it, because it was creating a lot of thing, and especially when your hands are a bit shaky, especially you want to access the subretinal space. Novice surgeon like myself, it will be a bit difficult and it's shaky. That transmits much more. And second thing, yes, we can take a new one, but the cost is pretty high. Precon and availability is also not that very easy, sir.
No, that's why I made the point when we are using 1,000 drug, another 1,500 for needle should not be an issue.
In the beveled end of that 26, the bevel is long, right? To amputate the end, or would you not want that sharpness to go into the because in your second video I saw some of that air came into the vitreous cavity and some of it went subretinal.
So these were the first videos. The second, subsequently, what I've done to make it much more easy to access it, I've bent the, like how you do a capsulotomy on the opposite side. Here it is bent towards the bevel side. You don't have to do anything. You have to just go sidewise. The mold is there. You go in the side. It just goes inside and then you inject.
Thank you so much. Wonderful. Now the next speaker, Dr. Vishal. Which side? This side. Vishal is video is surgical endoresection of choroidal melanoma.
Hello everyone. In this video, I will be discussing about endoresection of large choroidal melanoma. This is a case of a 32-year-old gentleman who presented with complaints of seeing brownish shadow in his right eye for the past 1 month. On examination, nasal pigmented large choroidal mass with overlying hemorrhages with exudation was seen in his right eye. Left eye fundus was unremarkable. B-scan image showed a mass lesion with horizontal basal diameter of 11.5 mm and a vertical basal diameter of 9 mm. Based on clinical features and imaging findings, a diagnosis of choroidal melanoma with retinal invasion was made. Full body PET scan revealed no abnormal uptake elsewhere in the body. Considering young age and 20/20 visual acuity, patient was opined for options of enucleation as plaque therapy is not advisable in large tumors, and endoresection, though rare but done in certain cases, as reported in literature. In this video, you can see novel endoresection of large choroidal melanoma. 3 ports are being made, followed by core vitrectomy. PVD induction is being done here. Following which, rest of the vitrectomy is completed. Here, PFCL bubble is being injected over the posterior pole. Cutter is being used for endoresection of the tumor. You can see the tumor size is being reduced gradually. Here bare sclera with multiple choroidal tissue is seen. Scraping is being done to remove as much as tumor tissue as possible. Following this, fluid air exchange is being done. Now endo laser is being done all around the tumor. High power of 600 mW with long duration is being used to laser the base of the tumor. Following that, air oil exchange is being done. Histopathology section showing cluster of tumor cells having spindle cells to epithelioid-like cells with conspicuous nucleoli and melanin pigments containing cytoplasm was seen. These features were consistent with pigmented neoplastic lesion. This is a post-op day 1 fundus photo showing lasered tumor margins with bare sclera nasally. Visual acuity was 20/80 on post-op day 1. This is a post-op 1 month photograph showing stable retina with epiretinal membrane seen over the macula. Thank you.
Thank you so much. Great surgery. Questions, please. Was there any follow-up PET scan done to see any systemic?
Yes, the patient is following for last 1 year, and every 6 months I do ultrasound abdomen, particularly looking at the liver to
liver,
look for, yes.
and that's one worry when you touch a tumor of this
There
dimension.
was a film behind the lens. I mean, clarity was not.
Yes,
You could
so
see something
yeah, so
behind
there
the
was
lens.
retinal invasion, there was a vitreous hemorrhage, so that's where there was some kind of blood clot which was stuck to the posterior
Stuck
capsule.
posterior cap.
Was there an injury to the tumor at the initial stage of the surgery? Because there seemed to be some blood.
No, there's a retinal invasion with vitreous hemorrhage, so that's what's kind of stuck to the posterior capsule.
Do you use anything in the infusion cannula?
No, no, no. I just for the because this was my first case, so I just did kind of triple freeze cryo to all the 3 ports, and I kind of use as much as possible not to go in and out with the instruments. So that's what's the only precaution about it.
How did you maintain the hemostasis when you're the tumor?
Yes, so the highest maximum pressure where actually when I was kind of endoresecting, it was kind of 60 millimeters mercury for that 2 to 3 minutes till that time. Other than that, I don't think so anything extra needed.
Wonderful.
Thank you.
Thank you so much. The next, the last but one is Dr. Rohan. Yeah. Yeah, Dr. Rohan is going to demonstrate his subretinal band removal from subretinal roots. We have his AV, please. One more. Oh no. Last but one. Thank you so much, Rohan. Open for comments, sir.
Rohan, I mean, how would you decide the location of the uh, external relation to the sub?
Fortunately, most of the cases which I have done, they were present temporally. So I did initiate it temporally. And in one of the cases, the second case you saw, one band, I had to take the forceps nasal also, just superior to the disc. If the retina is significantly elevated, you can make the forceps movement a lot, take it right up to the nasal part also. I've thought about it, whether I should make it on the nasal half, but presently I've done it only on the temporal.
Main advantage of this technique is not to make a retinotomy concept. Second case, there was one retinotomy made.
No,
So the very advantage of this technique was by making.
The main advantage which I think is that when you make a retinotomy, your direction of pull is not tangential, it is anterior-posterior, and sometimes that retinotomy tends to extend and it becomes irregular shaped and becomes a very large one. So here in the second case, yes, a small retinotomy had to be made additionally to remove that cut band, but then it's a controlled one and a small one. So that I think is better than the very irregular shaped retinotomy. The main risk when people think of this technique is of a suprachoroidal bleed or something. But then I found this that no bleeding happens if you control the IOP well.
Great video, Rohan. Well, I think has been on here. There are some uh, challenges also. One of them is that you have multiple subretinal bands. Go from one side, you try to remove, but do you want like another retinal cannula placement for the other areas, or you would you manage that? Some cases where extend.
So I mentioned it, it's not my original technique. I saw it being done by Dr. Khalid Sobti first, and I've done it. And like sir also asked, so from the same cannula, you can direct your forceps in multiple directions and maybe not go around all 360 degrees, and maybe the immediate opposite end would be difficult, but three quadrants you can manage with the same trocar.
Do you suture the
Yes, I put one Vicryl 7O at the port side after removal of the fourth.
think a novel concept, but really for it to be effective, you should be bit dexterous to use it on the other side also, so that the original need for a retinotomy is avoided.
Make it on the nasal side, then maybe your left hand you could use. No, no.
Thank you so much. The last video coming up, and I'll request all the participants to be around for a group photograph after this. The last video is by Dr. Nageshwar, non-leaky sclerotomy by modified triplanar wound construction for 20G vitrectomy. Very happy, and I congratulate the participant that they stuck to time.
Broker can list. First is up to the shoulder of the blade, up to the shoulder of the blade. The first entry is oblique, then making a second entry up to the tip of the cannula, then the third entry up to the base. The leak is tested by applying fluorescent needle test it. same, the silicon field I always. This is recorded by OCT, first, second, and third one. Maintains very good wound integrity. We've seen actually the recording, we will try to publish that. Almost all, if the conjunctiva was not dealt previously, very good, almost 100% cases don't require any suturing. Otherwise, suppose it has dealt, the conjunctiva is dealt, any buckling or any other surgery, suppose you have done, then in that cases, sometimes you may need this now.
Thank you so much, Dr. Nageshwar. Open to questions or comments.
Yeah, you are saying about conjunctiva previously dealt. My question is, if the trocar and cannula previously dealt, how does this
But
work?
almost, truly speaking, actually, we are doing hardly. Many cases we do. Many cases we do actually use.
I have a question where normally when we do the normal biplanar entry, it is the soft stop which guides us. We first go oblique, and where the cannula, there is a soft stop where the cannula starts, and then we go perpendicular and we go in. What is guiding you here? I mean, do you make some kind of a mark there with a
Marks.
pen? It's
That to the blade first end, connected to the of the cannula. Then the third one.
it's more or less just a little bit of feel
Yes.
which is guiding you.
Then great video. I have a question. If you have done this on like resurgery, silicone oil removal, we tend to see after that the done on those cases.
Then works well.
Great. Now I have a minute or two if audience wants to have any question to any of this. Otherwise, thank you so much. I request the participant to please come on the dais. Yeah, one comment, and then we assemble for the photo.
Like in the last video, I have a comment like the valve will be absolutely airtight or watertight when the length of the scleral tunnel is very long.
Yes.
What he is doing, he is just making an oblique entry first, then slightly vertical, and then again oblique, so that the length of the scleral tunnel that is giving the valve action, that is actually horizontal. So when you are placing the infusion cannula will be oblique, not towards the center of the vitreous cavity.
Yes.
So that any time it can go to the suprachoroidal space, air or fluid that can land up with other pulmonary detachment along with the whole dialysis, all these things.
That may occur, but the thing is, we never saw any.
Number two.
That's a good observation. I'll just make a quick counter. I think what he's achieving here is a triplanar. That means
Triplanar. That is,
it's
non-leaky.
No,
I know it is non-leaky,
it is because it is triplanar. It is offsetting the the efficacy by being smaller.
Okay,
sure.
For to be uniplanar, it has to be longer. But because it is at two different levels, it can be shorter and it will still be effective.
But
That's
for
the
the
idea.
infusion cannula, the cannula should be absolutely perpendicular to the vitreous cavity to avoid the other undue complications. This is for the comment of the last video.
For the submacular hemorrhage that Dr. Ramanujan has already shown, I have a comment that the diameter of the 38 gauge or 41 gauge cannula, it is 0.12 millimeter. So he is using 26 gauge. That diameter is quite large. That is creating a break. And when the patient is in supine position, he is injecting the anti-VEGF, TPA as well as the air. That is the that is the solution. And when air is blocking this break, when the patient is in upright position, sometimes what happened during intraoperatively, the subretinal air is going to the periphery. It is not getting that break. This is blocking the break. And when patient is maintaining his upright position, propped up position in the initial period after surgery, when to just displace the lysed blood inferiorly and the air bubble will go up, that will not block the break. So one thing is creating the break, it is not self-sealing. Second thing is air is not blocking in the immediate post-op period. So when the retina is detached, in case of huge submacular hemorrhage, that may land up in, he's fortunate enough that all the retina is totally on, but there is always a risk of postoperative retinal detachment.
Thank you. Thank you so much to all judges. May I request the participant to please come for a quick photo? Can I request MS to please come and join us for a second? It will be an honor to have you here with us, sir. Mahesh bhai, yes, please come. A group photograph with the faculty and the judges. MS is coming, so let him join us.